We'll talk briefly about skiwara, which is a uniquely pediatric type of injury. We'll talk about cervical spine clearance and the challenges that it brings with pediatrics, when to intervene in children, bracing options, fixation and bone graft options, and then growth considerations after surgery. So in terms of biomechanics, these are a lot of the reasons that biomechanically the pediatric cervical spine is different than adults. You've got a disproportionately large head sitting on top of a neck with underdeveloped neck musculature. You've got spinal ligaments and joint capsules, which are more elastic than the adult population. You've got shallow facet joints that you can see over there. You've got anteriorly shaped vertebral bodies. You've got immature uncinate processes, which aren't developed until around 12 or 13 years of age. And you've got discs and so forth that are more elastic. A lot of this was worked out by Dockling, Pang, and others, over 20 years ago. What this all combines to biomechanically is that for any given load, the pediatric spine is more likely to sustain an injury, whether it's inflection, hyperextension, or distraction. So, in addition to biomechanically different, the issue with children is that the spine is still growing. So even though biomechanically the spine matures around 9 or 10 years of age and becomes more like an adult type of spine, anatomically the cervical spine in young women doesn't mature until around 13 years of age and about 15 years of age in boys. This is a study that Cormac Maher put together about a little less than 10 years ago, which is the first time we really understood from a cross-sectional analysis when the spine anatomically stopped growing. Within that growth, vertical growth across the craniovertebral junction accounts for about 25% of it, and then subaxial spine about 75% of the vertical growth. In terms of the spinal canal diameter, you can see in that graph at the bottom, it's pretty much mature at around 4 years of age. So the canal doesn't get any wider after about 4 years. So in terms of etiology and problems that we deal with in the cervical spine, I put trauma and congenital at the top there because depending on where you are in the world and which study you look at, the two most common etiologies are trauma. So if you look at a center like Utah, then something like trauma is going to be the most common. When you look at other centers, this is a study that Todd Hankinson, this is a multi-center study, multiple centers across the United States. You see the most common etiology is congenital. So trauma kind of stands for itself. In terms of congenital, with pediatrics, you're talking about things like basilar vagination, Chiari's, instability from congenital anomalies like occidentalization of the atlas, Down syndrome, skeletal dysplasias, bone softening syndromes, underlying genetic conditions, and in fact, overall infection and neoplasia in general are less common. So when you see a cervical spine in a young child, excuse me, you have to keep in mind that certain imaging considerations, because those bones are not fully formed, you've got synchondrosis, you've got growth plates that are not fused. I can't tell you the number of times kids have been transferred into my hospital after the kids had a minor fall or fell off the changing table with an outside adult radiologist considering saying there's a Jefferson fracture because they're looking at the ring of C1 and it's a growth plate which hasn't fused yet, and the concern is for a fracture. So you want to keep that in mind. The C1 ring synchondrosis don't fuse until around 3 years of age. The C2 central synchondrosis, not around 8 years, and the tip doesn't develop until around 12 years of age, and occasionally that can be confused for like an ostodontoideum type of thing. C2-3 pseudosubluxation is something that's very common in the literature. Something like 30% of kids, young kids, will have that pseudosubluxation at C2-3. In terms of motion with flexion extension films, the Atlanta-Dens interval, because the cervical spine is more flexible in young children, we typically allow movement of the ADI up to about 5 millimeters, and then usually around after 8 to 9 years of age, when the spine again biomechanically becomes more like adult, then we go down to the kind of the tried and true white and Punjabi understanding of biomechanics around 3 millimeters at that age. And then Down syndrome is entirely separate. I'm not sure exactly why we permit that amount of motion or why that we would think that's safer, but we know that in kids with Down syndrome, because of the shape of the occipital C1 joint, as well as the ligamentous laxity at C2, that we typically allow more motion in those kids before we recommend intervention like fusion. So in terms of radiographically how to determine instability, when you talk about the craniovertebral junction, it's a very hot topic. There's a lot of clinical equipoise. Occasionally you can have a situation where you've got clear instability, after a trauma and so forth, or translational motion. But when you're talking about these Chiaris or complex Chiaris and congenital malformations, basilar invagination, when to pull the trigger and define someone as unstable is not an easy thing to do. And we actually just put together a recent Delphi study with a group of experts looking at that, trying to make some progress with that. In terms of the subaxial spine, it's a little bit more clear. We generally consider the pediatric spine to be more flexible, as I mentioned, but also has greater recoil. So when you're looking at a kyphosis like you see there, whereas an adult we allow up to about white and Punjabi, adult criteria on the left, we allow about 11 degrees of angulation. In pediatrics, we get worried if it's more than 7 because the pediatric spine has greater recoil, which means if you're in flexion, it should come back to a more normal position. But as I mentioned, the subluxation, because of ligamentous laxity, we allow a little bit more in young children. So what about sciora? So we're talking about spinal cord injury without radiographic abnormality. This was initially described by Dakling Peng and others back in the 80s. But back then, the initial description did not include MRI. And so if you go back and look at a lot of those studies, which has been done by Dakling, the vast majority have abnormalities in MRI. So these days, sciora should really only be used for children that have a spinal cord injury, have normal plane radiographs, normal flexion extension, normal CT scan, and normal MRI. And this is definitely a much more rare event because the sensitivity of MRI is so high. But the idea, if you look at the literature in trauma reports, at least historically, the rate of sciora would be anywhere between 5 and 70%. So when the range is that high among studies, you know that people don't agree on how to define it. But this, again, is a uniquely pediatric problem. I think the oldest person reported in the literature is probably 8 or 9 years of age. And again, the idea is you've got transient ligamentous deformation of the spine. They can happen in young children that allow an injury to the cord, but then it recoils back to a normal configuration. And they've done anatomical studies showing that, with a stretch injury, the spinal cord or the spinal column, the bones and ligaments, you can stretch up to 2 inches before it ruptures, but the spinal cord can only be stretched about, a quarter of an inch. So you can see how the tolerance for movement of the spinal column in young children is much more than the spinal cord. When this happens, we recommend doing an MRI to see what type of injury, ligaments injury you might have, and to evaluate the cord. We do radiographic screening of the entire spine. You do a dynamic flexion extension to see if there's instability in any way, and then typically these are managed with external mobilization. Historically, these kids would all go in halos. I think there's been much more push to putting these in collars, just because a lot of the times these kids have an injury that will recover, and usually we keep them out of sports for a little while until we know, in a delayed fashion with flex extension, that neurologically they're fine and they don't have any dynamic instability. So cervical spine clearance is something that takes a lot of time, and in pediatric, again, it has unique considerations. For adult patients, when they come in, remember when you're clearing a cervical spine, you have to clear the bony injury, which can be seen on a CT scan, but especially in pediatrics, most studies show that the chances for ligamentous injury are higher than the chances for bony injury. So clearing the ligamentous injury component of it in a young child can be difficult if they're not communicating to you and so forth. So there are a lot of different clearance studies out there. I only brought this one, and we don't have time to go into detail about how to clear the spine, but this was a really nice paper put together as a Delphi study, which include pediatric neurosurgeons, pediatric orthopedic surgeons, pediatric ER docs, pediatric radiologists, and it came to a consensus-based algorithm to clear the cervical spine based on admitting GCS and so forth. So if you haven't seen this before, this is a really nice study, and if you're looking for some type of clearance protocol where you work or in your hospital, this is the one that you might want to take a look at. So When do we intervene in children? So the vast majority of traumatic injuries and congenital anomalies of the subaxial spine and craniovertebral junction don't need intervention. A lot of these congenital abnormalities, they're born, the kids are born with them. They don't lead to symptoms, they don't lead to pain, and they don't lead to progressive deformity. But just like adults, this is one of the similarities. When we intervene is similar to adults. When you've got spinal cord and nerve root compression, when you've got progressive deformity, when you've got overt instability or too much motion, and you're concerned that the spinal cord's at risk, or you've got incapacitating pain, which in children is pretty rare. In terms of bracing, you guys have probably seen all these types of braces here. You know that all those pictures are of models because you'll never see a real kid smiling like that when they're wearing a brace. It just doesn't happen. But similar to adults, we've got everywhere from a collar, which are fitted and of different sizes, up to a traditional halo. Most time braces are used after trauma. It's usually uncommon to put a child with a congenital anomaly in a brace, unless you're just trying to stall. And because of instrumentation issues or something like that. So let's move on to the good stuff, surgical intervention. In terms of at the craniovertebral junction, until about 20, 30 years ago, we were left, the only option we had are bone and wiring constructs. And this still is true in some unique cases or very rare cases when children are very, very young. It doesn't really matter what type of wire construct you use, but the best results, even with a halo, are about 80% fusion, again, because it's non-rigid fixation with a wire. In terms of if you're going to put in screws in the cervical craniovertebral junction, got all the same options as you've seen or know about in adults, whether you've got transarticular screws or lateral mass screws or PAR screws, translaminar screws, condylar screws, C2 pedicle screws, odontoid screws, and multiple studies have shown that with rigid fixation, the success rate of surgery, the incidence of fusion is much higher, probably over 90%. Using rigid internal fixation at the craniovertebral junction, it's the only level 2 evidence available for treatment of pediatric spinal injury. There are multi-center studies done through the Paediatric Spine Foundation and other organizations which demonstrate this. So that's not news to anybody. When you're doing this in a child, one of the key things is that you've really got to be careful with the preoperative planning, because if you're taking a 3-year-old child to the operating room and you're going to put in screws, you have to make sure that that it's anatomically, technically feasible to put the screws where you want to put them. In a 3-year-old child, you may be used to using, if you're doing an OC fusion construct and putting screws in the keel and then putting screws in the C2 pars and putting 14, 16 millimeter screws in the pars, you're not going to get a 16 millimeter screw in the C2 pars of a 3-year-old. It's just anatomically, it's not big enough. So you got to know, based on the CT scan, or if you load it up on a workstation or a 3-dimensional imaging system, that's fine. But even just the CT scan, you got to know where you're going to put your screws before you go into the operating room to make sure that the screws are available for you to put in at the size that you want, and so you're not trying to put in screws where it's not going to be anatomically feasible. There are other studies show that when you're doing, probably the most common surgery we do with the craniovertebral junction in kids is an O2 fusion. When you're doing that, there have been studies that show that you don't need to put screws into C1. If you've got good screws in the occiput and you've got screws that anchor at a C2, it doesn't matter if you use transarticular or if it's C2 pars or C2 pedicle screws, the studies show that the fusion rate's about the same. And in a kid, every time you're getting down to that, putting that C1 lateral mass screw, there's a big vertebral flexus. You always get some bleeding there and so forth, so you don't have to put a screw in at C1 if you don't need to. Growth still occurs across the construct. I'll show you that a little bit in a minute. And then in terms of risk factors for fusion failure, Down syndrome for at least C1, C2, and congenital etiologies are risk factors for fusion failure at doing O2s. So what about bone graft? So structural autograft, whether it's rib or iliac crest, has always been the gold standard, but certainly based on the adult literature, in peds we've moved kind of away from that, and we've started using, at least for 10 years I was using structural allograft, just because you save an incision, operations 30 minutes faster, and based on cross-sectional insurance administrative databases, there was no difference in fusion outcome. But very recently, which we're going to present later, we did a study through the Paediatric Spine Foundation, a multi-center international study, which showed that the use of structural rib autograft was an independent risk factor for fusion success. There's a 75% increased odds of fusion if you used structural rib autograft compared to anything else. So based on this, changed my practice back to using a structural rib autograft. BMP is rarely used in kids, really kind of crazy cases and so forth, just because the bone healing in children is so much better. But for at least preliminary reports suggest that it's safe. What about subaxial? When subaxial, we've got the options of go from the front or from the back. In terms of screw placement in the back, again, similar to adults, you've got lateral mass screws, pedicle screws, laminar screws, or in rare cases when young kids, just a posterior wiring construct. If you're doing the anterior approach, typically we do that when the anterior column is most disrupted, get from C2 down to T1. We usually put an inner body in there. This is all not news to you guys. The key thing, this is a table looking at different instrumentation companies and the sizes of their plates. So it's difficult to do an anterior construct with traditional adult spinal instrumentation in kids less than probably 3 or 4 years of age, because the bone just isn't big enough. If you look at the screw size there, the shortest screw size you can get is about I can't even read it, I don't know, it's 10 or 12. But in a 3-year-old kid, the body may not be that big. And so you try to put those adult screws in, and you go through the back of the body, and you're gonna be touching the cord, which you don't wanna do. So again, you gotta look at the anatomy, you gotta look at the CT scan and make sure that your instrumentation system has screws that are small enough to put the screws where you want them to go. Remember, in the pediatric spine, anteriorly, you've got larger disc spaces, and the bones are smaller. So if you go in there like an adult case and you start scraping out that disc and you're really aggressive getting on that end plate to make a nice area for fusion, you scrape all that out and you may not have enough vertebral body left to put your screws in. So it's just something to keep in mind. Again, determine the technical feasibility of that. With the posterior approach, so we typically do a posterior approach in the subaxial spine when the posterior elements are disrupted. Again, we can use a wire cable constructs, but that's usually it's a last resort in kids that are very, very young. Lateral mass screws are the most common. There are a lot of different techniques for putting in lateral mass screws. If you look at the top figure on the right there, remember the lateral mass, the vertebral artery is going medially, the nerve root's going inferiorly, so your entry point's going to be somewhere kind of in the lower left, or the lower medial quadrant. You're going up and out direction. Laminar screws, typically we use those at C2 and C7. The lamina in children is pretty small, and most of the time you're not going to get laminar screws in there, or if you do, you're only going to get one screw in there. Pedicle screws in children have been reported. They're almost always placed with navigation. There are 1 or 2 series out there. Pedicle screws are great in the subaxial cervical spine. They allow a lot more biomechanical stability, but most children, you're not going to be able to get them in there technically. It's just the anatomy is going to be too small, but it's something to really consider if you've got situations where you've done some scoliosis surgery of the thoracolumbar spine, which Dr. Bonfield is going to talk about, and you develop a proximal junctional kyphosis, or if you've got like a high heavy vertebrae or resection or a VCR and you need that additional stability. Then if you are in a hospital that has navigation systems, it's something that you get much more biomechanical stability with the pedicle screws. And then typically the arthrodesis, we just use an onlay. And again, BMP is uncommon, but appears to be safe. So growth considerations, probably the single most common question that I get is how young can you put screws in the cervical spine? So this is a table we put together a couple of years ago, which you can see with the different type of screw placement and the youngest reported age that those have been placed. If you're going anterior in the subaxial spine and it's too small, like we've got some cases here we can show later if we have time, you can use a hand plating system or a OMF plating system, and you can get smaller screws in a plate, which can probably help you hold the graft in place, but the biomechanical stability of those is totally unknown. So if you can stall till they're old enough and you can use a traditional plating system, we know the biomechanics are much stronger, but sometimes your hand is forced and you just got to do it. So, lastly, we'll talk about growth considerations. So, probably the second most common question that parents ask is, well, what's going to happen with my child's, this growth of the spine? So we looked at this in the neck, and we've done a couple multi-center studies looking at this, and it turns out that when you put in screws, if you do C1, C2 fusions, you get about a third of the growth of the cervical spine still occurs within the construct. And it's probably because you're only doing 2 levels and you've got remodeling of the bone above and below the construct. If you do O to C2, almost 80% of the kids will have some growth there, but it's reduced. It's probably about 18% of the growth of the cervical spine. Very few patients develop significant hyperlordosis, which has been reported, and unintended fusion or development of swan neck deformities and so forth is very rare. In terms of the subaxial spine, it's a little bit similar story you might expect. If you look at the graphs on the right, the red line is what normal growth is. If you do a 2-level fusion or 3-level or 4-level based on anatomical growth, and then the blue lines are what really happens. So you can see that if you're doing a 2 or 3-level fusion, then the growth is pretty much the same. You really don't inhibit growth. But if you get into the 4-level fusion, you see the slope of that line really tailoring off and affecting a little bit of growth there vertically. So to conclude, the pediatric spine is different from the adult spine anatomically, biomechanically, the etiologies. Trauma and congenital anomalies are the most common indication for intervention. The preoperative imaging, looking at that CT scan is really critical to determine the technical feasibility of putting in screws. Structural autograft is the gold standard now for occipital C2 fusions. Take special note when you're dealing with Down syndrome or congenital anomalies because there's a high risk for fusion failure. It doesn't appear that when you put in screws, you don't stop growth of the spine. It can limit it, but it doesn't stop it. And when you're doing these surgeries, and especially in young kids, it's really important to follow these kids' overgrowth to make sure that things, don't develop over time. But the whole point of this is to stabilize these kids so that, it will avoid catastrophic accidents that you guys may have seen in films before like this. So we don't want our children meeting Jet Li in the back alley. So thank you very much. So what we'll do next is we'll invite Dr. Bonfield to come up here. Chris is from Vanderbilt, a good friend of mine, a real expert in not only cervical spine craniovertebral junction, but also thoracolumbar deformity and scoliosis. Does a lot of great work here. So Chris will talk to us about the rest of the spine, and then we'll go through some cases and get some audience participation.
Okay, thank you. So we'll talk about thoracolumbar spine, go down the spine a little bit. That was a wonderful talk about craniocervical trauma, and yeah, that's perfect. And how it's different in children compared to adults. So let's see if... Okay, no disclosures outside of the fact that Nashville, Tennessee is in the southern part of the U.S. Down there. So we're going to recognize the common characteristics of pediatric spine thoracolumbar pathology, mainly focusing on trauma and then maybe a little bit of scoliosis at the end. So pediatric spine injuries are less common than adults for many of the reasons that we just heard from. The soft tissue stretch a little more, there's less fractures, and as far as thoracolumbar fractures, it's even less. So there's more cervical injuries in children than there are thoracolumbar fractures. So these are about 1% to 2% of all pediatric fractures. The risk for a neurologic defect goes down as you go down the spine too. So if you have a craniocervical injury, you're more likely to have a spinal cord injury that goes associated with it. Thoracic, lumbar, less and less as you go down the spine. And also older children, as far as thoracolumbar spine, have more TL injuries. So as you get older, the injuries move down the spine. When you're younger children, it's usually up towards the patient's head, as Rich has just explained. And the most common mechanisms are falls in younger children and motor vehicle accidents and sports injuries in older children. There are peaks in the summer and winter breaks depending on how your school systems are in your countries. For us, the kids are off over the summer, so they're out there doing more things and getting into more trouble, more accidents, more injuries. Also over winter break around this time, right around when Christmas, when they're off of school for a month or so, they're out doing more things. So initially, it's usually x-rays that we see. However, depending on where you are and depending on where CT scans is, CTs are becoming more popular for injuries to look at it. You can look at on x-rays or CT scans, look at the posterior elements, the anterior elements. Are the spinous processes splayed across that you can see? Are the joints disrupted? Is there deformity, coronal imbalance, sagittal imbalance? And then MRI, if you need to, is generally reserved for patients who have some sort of neurologic injury to understand why that injury is there, and if you need to do a decompression as well as just a surgical fixation or something like that. It can also show injuries to those posterior soft tissue complex. If you have a burst fracture up front, you need to know how are the soft tissue posterior elements posteriorly. Is this something that can heal on its own, or is there enough soft tissue injury as well that you think may need some sort of fixation as well? But MRI is generally reserved for less. If you had to pick one thing to look at, thoracolumbar trauma CT would be the best. X-rays can suffice in many places where CTs aren't around. There's different classification systems. I put a lot on these slides, not for us to go through everything. If you want the slides at the end, let me know and I can email them to you. But different spine classification systems about how to look at those injuries, try to determine what the actual etiology was, and more so how to predict whether or not they need surgical intervention. And that's the main point of these two studies. There's the AO spine classification, which added the TLIX to it, which is why it's TL AO spine, and then the TLIX as well. And again, I put these on here not to memorize, but know that there are a couple different injury classification scores that try to predict whether or not you need to have injuries or whether or not you need to have surgery. And they're all grouped together, so you get a score when you're done, and the higher scores lead for somebody to perhaps do more intervention than the lower score. So it gives you an idea about which fractures might heal on their own and which ones may need surgical fixation. Again, the TLIX is the same thing, takes into things like how does the injury happen, what does the injury look like, how's the posterior ligamentous complex, and is there some sort of neurologic injury? And with each of those, you assign a score, and if the score is more than 4, generally, we would recommend surgical fixation for this. So things to think about as you're evaluating it. The other things that these scores do is that whenever a resident or a med student or somebody else calls you, you say, I have a TLIX injury 5 patient, you have some idea about what they're talking about instead of them trying to describe it to you over the phone without seeing the films. So it kind of gives a common language about how all of this stuff works together, but more so it's trying to just predict the need for surgical intervention. We'll go through some of the common injuries here, like Rich did for the cervical spine. Thoracolumbar spine injuries generally look more like the common adult injuries that we see because these are generally older children, so past the age of 8, generally teenagers, where the actual biomechanical part of the spine looks more like adults. So you start to see more fractures, less of the soft tissue ligamentous injuries, things like compression fractures, which are the most common injury that you see in adults as well. It's usually axial loading from top to bottom, and most of these generally don't need surgery. You can see a couple little compression fractures about, at the top of that CT scan over there about T5 and a little lower on these ones over here. And most of these are stable. And if you go back to that TLIX score, this is an actual TLIX 1, so as low as you can get on the scale. And most of these don't need an operation. Sometimes we put them in braces, sometimes they don't, but these most of the times they heal on their own. Burst fractures are a compression fracture with that also involves not only the most anterior part of the vertebral body, but involves the posterior part of the body as well. And you can see in those scans over there, the CT scans, the MRI scans, that it's fractured on the top of the body, the front of the body, and the back of the body. And these ones oftentimes can have retropulsion of the bone towards the spinal cord. Sometimes there is some sort of neurologic injury as well, depending on where along the spine that you are. But the vast majority of these ones, the patients are actually doing fine. And then you have to decide, is this unstable enough? What do the joints look like? Is there kyphosis? How is the posterior element in those soft tissues as well? So if it's just a burst fracture up front and the patient is doing fine and the overall alignment looks good, most of these will heal up on their own. But if there's increased kyphosis, like in this patient where there's 2 or 3 burst fractures on top of one another, so it's leaning forward, or if you look posteriorly and you look at those spinous processes in the back and they're starting to splay open, even if you don't have MRIs to look at them, you can look at a CT or X-rays and realize that there's more space behind them, that something was stretched or torn, and those ones may actually need surgery. So again, this is sort of the second in line of going from least severe injury moving up. Flexion distraction injuries or chance fractures, meaning that oftentimes you see them in car accidents with seat belts, whereas the car stops abruptly, the seat belt is across the waist, the child moves forward, and the spine stretches and fractures. And these can be three-column injuries is usually what they are. So it's the anterior column in front of the bone, the middle column in the back of the bone, and the posterior column behind the spinal cord. And these are generally unstable fractures because you have all three columns that are fractured. They generally can have a neurologic injury because they're stretching through where the spinal canal is, and these can either be directly through the bone, which is what some of these show, which is that top one up there where there's a fracture right through the bone, or it can be strictly soft tissue. If you look at the bones down on the bottom one over here, the bones are fine, but you can see that there's angle of the disc space, and if you look posteriorly to the spinous process, there's a huge gap there. And so the patients not only flex forward, but they distract up, and they essentially tear across the entire spinal column. These ones generally do need surgical intervention, if you can, just to stabilize them. The difference between the children and the adults is that if you look at this bottom one, that child was only 6 years of age, and so instead of the common teaching with fractures is 2 up, 2 good ones up, and 2 good ones down, so you get these longer constructs. With a child who's 6, we're going to try to limit that as much as we can, so it's actually 1 up above where the fracture is and 1 down below. And they tend to heal much better as well, but you can see how big those screws look in those vertebral bodies compared to the ones up top, which is a more teenage patient. So things to think about as you're fusing somebody who might be who still has a lot of growth left. Fracture dislocation is the same type of idea where it's where you're stretched and then it moves. These ones are generally more severe where it's not just flexed and then torn posteriorly, but the whole spinal column moves. These generally are from some high impact, either falling from a really big height or having some sort of high-speed injury. These ones usually do have some sort of neurologic defect as well, because you can imagine that the whole spinal canal and column is moving and the spinal cord inside gets injured. This does require surgical intervention, basically to stabilize them, not necessarily for any sort of neurologic return, because oftentimes the spinal cord is injured past any point of repair. But if they heal in that direction, their overall posture alignment isn't good. They can have pain in the future, and oftentimes they may not heal in that way and continue to fall forward. So depending on where you are, and I realize that there's resource allocations about which patients can have screws, which don't. When you're talking about complete spinal cord injuries, those patients generally don't do as well compared to ones that are neurologically intact or incomplete. But it's something to think about, that this is a fracture that's unstable, at least up front. And also the other difference is, I know in many places, is that some of these spinal cord injuries arrive to your hospital many days to weeks after the injury happened. And so you may not be able to actually reduce that quite as well, because it might have started fusing in that way compared to somebody who would have shown up that day or a day or two later. Skywara, Rich talked about, it's more commonly seen in the cervical spine, so we'll sort of skip it over here, but it can be seen down towards the CT junction. There's one, again, it's not really Skywara if on the MRI scan you can see the actual hemorrhage in the spinal cord, but if you got a CT scan of this, it would look completely normal. So again, depending on if you have MRIs or not, to try to help explain why the patient has their neurologic injury that they have. But the vast majority of these do not need surgery because all of the soft tissue around the spine is still intact, and it was the spine was stretched too far. So again, a collar or just immobilization, or if this is down in the patient's thoracic spine, they probably don't need anything really, but just to try to limit their activity as the spine's healing. The long-term outcome with any of these things is that basically the worse you go in, the worse you come out. Or if you come in looking really good, you're probably going to do fine on the back end as well. So it's the neurologic exam and presentation at the beginning that sort of predicts the outcome more than anything else. Neurologic function does occur in children more than adults. That goes with everything. Same thing with head injuries as well. So as pediatric neurosurgeons, it is nice to have some kids who came in with serious injuries. You stabilize them, give them time, support their blood pressure, do all the things you need to do to try to get that spinal cord every way to heal. And oftentimes they will actually surprise you, and come walking into clinic 6 months later. Complete spinal cord injuries generally do not get better, even in children. Those are the ones that have the worst outcome to begin with. And so again, depends on what they look like when they come in, how they're going to look whenever they come out. And incomplete spinal cord injuries, depending on which study you're looking at, anywhere from 1/4 to 3/4 of kids actually get better. So these are, when you're talking to parents, if there is some motion there, if there is some sensation there, there is a chance that they can get better over time, which is very different than adults and older people. So the key points, these are rare injuries in children, but as you start getting into the teenage years and the spine looks more like a full-grown adult, we start seeing thoracolumbar injuries more. They are different than adults. They do have increased soft tissue ligamentous laxity, as we talked about in the cervical spine, but by around 8 to 10 years of age, their spine starts looking like adults. And again, these fractures are generally in that population, not the younger population that Rich was talking about earlier. If you can diagnose them early, follow up, you have to see them long range because these kids are still growing. So whether or not it was a burst fracture or a compression fracture that didn't require things, make sure that if they're on that growth spurt time that they get through that and that some sort of deformity doesn't form later on. And if you can, you need to limit where you fuse, whether using instrumentation or whether you're putting bone graft in. You want to limit that area because these kids are still growing and trying to limit how much growth that you're blocking down the line. And in most patients, conservative management does work, and that's either with a brace, which is kind of used less in these areas compared to neck collars, but most of the time with these, a lot of these bony fractures themselves, compression fractures, some of the more limited burst fractures, which are the most common two fractures, they're healed without surgery. So that's sort of a whiz through the trauma side of things. I introduce spinal deformity here because as pediatric neurosurgeons, we're starting to be more and more involved in this world. I mean, generally orthopedic surgery, at least in the U.S., for pediatrics, this was, they did most of these cases, but with our training and with collaboration between ortho and neurosurgery, this is becoming more commonly done by pediatric neurosurgeons as well. And I know in other places of the world as well, pediatric neurosurgeons or neurosurgeons in general who are doing spine will oftentimes operate on children. So when we think about this, we look at it in many ways, but sort of the overall view of what the deformity looks like and how do you measure that? And there's this thing called a Cobb method, which is very simple. It's measuring the top of the curve and the bottom of the curve and what's that angle in between basically those two lines. And scoliosis by definition is over 10 degrees of that. And so less than that, you can have somebody who just may be leaning in one way with some muscle spasms. 10 degrees is really, really low, and you can have a minor scoliosis of 10, which probably doesn't affect anything moving forward, but that's the formal definition of scoliosis. It's very common. So you're talking about something that's between 2 and 4% of the overall population, and I'm sure there's somebody in this room that has a little bit of scoliosis as a teenager. As we get older into adult degenerative scoliosis, which is very different than this, it's actually close to 50 to about 70%. So as you get older, a lot of patients have some sort of scoliosis as they get older. It's most common around the period of growth, which is between about 10 to 15 years of age. The females generally start growing a little before the males. The prevalence is about the same in the young kids, so females to males is about the same in the small curves, but as the curves get bigger, and generally the ones who need treatment are much more females, so about 10 to 1 females to males on curves above 30 degrees. And we used to screen for physicals at school where everyone, bent over and you looked at the back and saw whether or not there was a rib hump. There's some people in the States that say maybe that's not necessary because we're getting x-rays on too many people, but the groups that deal with scoliosis, which is orthopedic surgery, the scoliosis research group, the pediatric group, all say that you still should screen girls at about age 10 to 12 at the onset of growth spurt and puberty, and boys a little later at about 13 or 14. So we still think that it is worthwhile screening these kids, and if you look at their back and you see a rib hump, then you can get x-rays to see what you need to do about it. Overall, there's many different types of scoliosis depending on what the reason is. Congenital means there's something wrong with the bones that was formed. The hemivertebrae, the ones that look like wedges, which will send your spinal cord off. Neuromuscular, things like cerebral palsy, spina bifida, myelomeningocele, these are very common across the world. Marfan's, osteogenesis imperfecta, neurofibromatosis, tumors, things like that will change your spinal cord and the strength to maybe one part of your body because of that. And then idiopathic is the main one, where we don't know why. Everybody has a straight spine, and puberty hits, the growth happens, and then the spine starts turning. And when you look at that, it's about 90% idiopathic out of all of that, at least in America. In other parts of the world where there's a little more prevalence of having cerebral palsy, spina bifida, that might be a little different. But most of these kids are completely normal, and then they hit puberty and their spine curves. Congenital, you can see where that little hemivertebra is, the nice square bone stacked upon one another, the hemivertebra up top, which sends the curve to the side, and then the other compensatory to curve to bring it back in. Bracing, generally speaking, doesn't work with those because it's hard to push the bones back into place whenever you have an actual anatomic problem. But it's something that we think about, and some of these are the ones that you'll actually fix as a small child, where you go in, take that little hemivertebra out, do one level of fusion above, one level of fusion below, just to try to straighten it out if the curve's bad enough when they're really young. Not a big fusion like that, but something small, so as they grow, you try to keep them in more balance. Neuromuscular are the big sweeping curves, higher complications when it comes to this, bigger operations, more blood loss, more lung issues, more wound infections, more everything. And so these are harder to deal with, but these are the kids with cerebral palsy, spina bifida. And the reason you're doing these operations is to get their hips flatter so that whenever they're sitting in their wheelchair, they don't have wounds on their hips. And also you can start having breathing problems when you start getting into these big curves of 90 to 100 degrees. So it's a very different reason about why we fix these things compared to the idiopathic, which is generally speaking a normal girl who then hits puberty, their spine starts changing. They can get up to big curves as well, but these are generally more normal kids without other medical issues. And you're fixing this because you don't want this to actually get worse over time. And most of them don't have pain. Most of them don't have any problems with this. Some girls don't even notice that they have this, or they're just minor cosmetic deformities. But if it gets past 50 degrees, it'll continue to worsen over time. So we fix them as a child when it's still flexible. Idiopathic is broken down a couple ways just by the ages, depending on when it comes in. The infantile ones are young ones. These are rare. Sometimes they actually get better on their own, but you could do things like casting or bracing, or hopefully as they stand up or mature, that these actually get better. If they don't, it's really hard to deal with because you have big curves in small children and not much treatment options. Just like this, if they're between 4 and 10 years of age, can you start putting in things like growing rods? And there are people, some of our colleagues from other places in the world, you don't need fancy systems to do this. You just need 2 rods and a little side-to-side connector. And so every 6 or so months, you go in there, you open up that connector, push the spine up about 1 centimeter or so, or 2, and over a period of years, you try to get that lung cavity get larger and larger and larger until they're about age 10, where you can formally fuse them. So this is all about getting the lungs big enough to set themselves up to have lung capacity that can support them when they're older. Because you can imagine if you fused a 6-year-old and they have a 6-year-old sized lung for the rest of their life, they're going to have problems breathing when they get older. So there are ways of doing this without fancy connectors. You don't need anything crazy. You just put a side-to-side connector in there and push those rods apart every 6 or so months. The adolescent one's the most common by far. A small curve like this, you just watch. If it gets bigger, you can brace them, which will hopefully slow things down. And ultimately, if the curve's past about 50 degrees, you end up thinking about a spinal fusion, because those are the ones that get worse over time. So you have to think about, where are they skeletally? Are they old enough to undergo a formal fusion? Where is the curve? Is it going to progress? What's the age? Is the curve big? Is it small? And what the actual size of the curve is. So bracing is generally done with younger children who have growth remaining. There's no point of bracing somebody who's finished growth, because that curve is sort of fixed in that way. It may progress slowly over time, but you're not going to slow it down. So these are younger kids with curves in the 20 to 40 degree range that you're trying to keep very small. So whenever they hit skeletal maturity, it's a small enough curve that you don't need to fix. And there's all sort of different braces around the world. But the main thing is just try to slow that curve down so that whenever they're done growing, it's as small as possible. And then you start talking about bigger fusions and curves that are above about 45 degrees, because those will get worse even after they're done growing. They get worse about 1 degree per year is what the teaching is. But that's why when we talk to families, the teenage girls say, hey, I feel fine, my curve, I can't see it. Why are we doing this big operation? And it's try to prevent a problem 20 years down the line. So overall considerations, you need to know why the scoliosis curve is there in the first place, what growth is remaining, skeletal maturity, flexibility, how big is it, that matters. And then there's different treatments along the way that range everywhere from observation to maybe casting, bracing, growing rods, or a formal fusion when it comes down to it. All right, so thank you. Yeah, I think it was just a word that people use for some sort of transient neurologic injury to the spine. So we see these, and whether they call it spinal cord apraxia or other things, like you see them, I'm assuming you see them with hockey injuries, somebody gets hit into the boards. It's not a stinger, it's not just one arm that goes numb for a second, but all four limbs go numb, or they can't move at the waist for a little while. They get to the hospital, they start getting better, they may even be fully better, and they get all the imaging and it's normal. And they say, well, what do you do with that, and what do you call that? We call it a transient neurologic injury or transient traumatic spinal injury, something like that. And I think that's probably what that ICD-10 is supposed to mean. The problem is what do you do whenever that kid wants to go back to playing hockey or football or soccer or whatever caused the injury in the first place? And we don't have a good answer to this. And we try to talk about expert opinions when it comes to this. Do they just wait out 3 months and is it fine? But you get MRIs to make sure they don't have a congenitally small canal and that maybe they're at risk to do this. Make sure they don't have a Chiari and something weird happened where that was the issue or other things. But I suspect that spinal cord concussion is that temporary injury, just like a concussion, theoretically is a temporary neurologic injury as well. So that's truly Skywara, but that's a temporary thing. And the hardest part with that is talking to families about telling them what activities the kids can do moving forward and what is the rate of this happening again, because nobody knows. Yeah.
Question? Thank you. Nice lectures. My question is, what do you consider removing the screws, especially in trauma? And what's the younger patient have you done, and you consider really removing the screw after a year or so?
I'll let Rich talk about something that he likes to talk about in a second. I know where he's going with this. But from a teenage standpoint, you basically leave them in unless there's infection or unless there's some problem. People talk about maybe the screws causing pain, but I think the screws would be causing pain if the patient doesn't have a fusion and the screws are loose. But as far as the general teaching from us is that if the screws go in, the fusion happens, everything's solid, the screws stay in. The little kids may be a little different, and if you're talking about fixation to the occiput and things.
Yeah, a couple different things on that. Just to follow what Chris said too, is there's an increasing prevalence of doing percutaneous screw fixation for trauma situations where you think it's an unstable thing, but it's a really nice way to stabilize the spine. The question, and this may have been what you're getting at, is whether you could go back and take those screws out. And I think the answer to that probably is yes, but as Chris mentioned, those kids do so well, and they really accommodate. And if you're doing a short construct, and they're asymptomatic, and they're doing all they want to do, and it's hard to take them back to the operating room to take those screws out. What Chris was alluding to was, when you've got very young kids, if we have time we can show a case, and you're doing, sometimes in a really young kid that has a big, horrible type of deformity in the neck, their bones aren't big enough to put in screws in the subaxial spine. You may be able to get something into C2, but your greatest points of fixation are the occiput and then down into the thoracic spine. But if they don't intrinsically have a problem at the craniovertebral junction, there's nothing intrinsically wrong in the joint, then what you can do is we like to instrument long and fuse short, where you take them, you correct their deformity, and you put in screws over a longer area of construct because you got better fixation there. But you only lay down bone graft where the real problem is, and then you can go back in a year after a CT scan or something after you've shown a fusion, and you can disconnect the occiput or something, and you can restore 40% of the range of motion at their neck because there was never anything intrinsically wrong at the craniovertebral junction. Does that answer, is that getting at what you were talking about?
Yeah, to some extent. It's just I had a 2-year-old fixed that trauma. And does that young patient, limitation of growth, that's my concern. It's not about the pain or just the limitation of growth.
Yeah, I think if you're dealing with the neck, the vertical growth is some limited, but it's really not that big of a deal. I think we've shown that. In the thoracolumbar spine, if you had to do a long construct over the thoracic spine in a 4 or a 2-year-old or whatever, then I think that's probably a situation where it would make a lot of sense if you think they're healed to consider doing that. Otherwise, because if you don't have a growing construct, and as Chris said, there are going to be big lung problems down the road. Other questions?
Okay, my question for the first speaker. At the last presentation, the slide from the last presentation, you perform occipital-cervical fusion and also extend to the cervicothoracic junction. So when you start to choose for the case, it cases need to perform, to extend to occipital and to extend to thoracic junction. How you choose the patient for every case?
Yeah, so we don't like to do that because those are long constructs and you're really going to limit growth of the neck. Typically, those types of surgeries are only done with severe deformities like complete spinal dislocations, or if you've got skeletal dysplasias where you've got big swan neck deformities, progressive kyphosis, spinal cord injury, and so forth. And those are kids typically you have to put in traction to straighten the spine, and then you do those long constructs to lock them in place. And then again, this is a situation where when possible, up front, you try to consider that instrument long and fuse short. But they're big deformities, and I'm not sure, we're probably going to run out of time, but I'm happy to show you some cases later of these long constructs. But they're uncommon. It's not common to need to do those very long constructs.
So long-term follow-up, what happened?
It's a great question. So we put together a series, multi-center series of about 11 patients over the course of 20 years. So they're the rare situations. In follow-up, just because I know a lot of the surgeons who did that study, probably somewhere between a third and a half of those kids have gone back to the operating room for a variety of reasons. At the beginning, people were using a ton of BMP, and there's all this bone overgrowth, and sometimes led to cord compression. Sometimes the instrumentation wasn't strong enough, and they had a progressive deformity through the fusion construct. But about somewhere between a half and a third of those kids have done fine and not needed further surgery. So it's not great. We need to do something better. What I'd love to do is set up some type of growing construct in the neck where you lock them in the occiput and leave the rods long to allow some growth, but I haven't done it yet. Have you done anything like that, Chris? Yeah, like a Schiller system for the neck.
I just wanted to follow up on the discussion on very young patients. And so say you have someone 2-3 months old who has a lower cervical spine dislocation with an incomplete injury, and you're probably going to be wiring. How do you decide timing, and do you go back for that, or would you do a long construct and then go back?
So in a 2 or 3 month old, I would stall. Number one piece of advice, stall as long as possible, because you can put those kids in a custom. They're not up biomechanically walking around. You can do, depending on where you are and your resources, you can get some pretty good braces and so forth. And I've had kids that with horrible deformities, not a trauma situation, but horrible deformities at birth, that I'm like, this kid's gonna need surgery right away. And I've put him in a brace and had a great reduction after traction. And the kid's 3 years old now, and the spine looks totally normal. I don't think I'm gonna have to operate on him. I mean, it's unbelievable. So stall as long as possible, because your outcomes are going to be so much better. You're going to have lower complication rate if you can get them to an age where you can use rigid fixation, which typically is a year and a half, 2 years of age.
So what kind of braces were you able to find, or do you cast when they're that young? We had trouble fitting.
Yeah, so I'm fortunate in my institution to have a brace guy that'll come by and do a fitted brace. And in a very young kid, there's really no chin strap. It's basically they're lying down. It's almost like an eggshell type of thing, exactly, with a thoracic brace. And then they have a headrest. And then the key thing there is to have them, if it's a neck deformity, is to have them put a bolster under the neck, because it's usually a kyphotic deformity, so that they can straighten it. But one of the things that really helps with that is if you can, even in a neonate, you can put them in halter traction, and you get an amazing deformity correction before you put them in the brace. So the brace is just maintaining that correction.
And most of those traumas in the kids are going to be soft tissue injuries anyway, so I don't think it's as important to get some rigid fixation in there, right, as give them time to let all that stuff get tighter again. And you're right, I mean, don't put instrumentation in a kid that young if you can avoid it.
Yeah, yeah. We're almost out of time. Other questions?
What the most complication occur after surgery for long-term follow-up?
Yeah, I think it depends on what age you're talking about. If it's the adolescent children or child who's done growing, I think probably the longest complication, and we don't know this yet, is going to be sort of arthritis above and below where the construct is. So if this is a 15-year-old, it looks good right now, and the point of leveling that is so that the lumbar spine is in good alignment. Everyone gets arthritis, degenerative changes as they get older, but if it's tilted, there's probably an increased risk for that. But what we don't know in the long run is what that kid looks like when they're 60. Because I've had a lot of ones from 20 years ago, which is basically Harrington rods. So there's a hook at the top, a hook at the bottom, and then a big rod in between. And while it stalled the progression of the scoliosis, so which is great because that was the point of it, because now they're not a 90 or 100 degree curve, they're stuck at 30, but the bottom of the spine is still curved coming out this direction and going back in, and you're starting to see degenerative arthritis maybe a little earlier. And those are some people who were then extending the fusion down to S1 or things maybe earlier than we would. And so I think from an overall safety standpoint, we've done really well. The kids generally fuse up front really well, so the rate of having hardware failure is much lower in kids than in adults. But we don't know what happens to the spine above and below it when there's more motion or more stress on those two areas in the very long run. So they're fine at 5-10 years, but what happens 40 years from now?
I think we're out of time, so we can take any other questions after that. Thank you so much for joining the session, and thanks to Chris and our faculty. Thanks so much, guys.